Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about kidney function, we're going to talk about diuretic agents, and some general GI tract anatomy. If you're new to the podcast, just to briefly explain, I ask questions to AI and AI explains these concepts. Take everything that it says with a pinch of salt. Sometimes it might make a mistake. Make sure to cross reference the information. Nevertheless, I hope you find this information valuable and you find the podcast enjoyable overall. So, Grok, shall we get started with kidney function measurements?
All right, let's dive into kidney function measurements. The kidneys filter blood, remove waste, and regulate fluids, and we measure their performance with a few key tests. The glomerular filtration rate, or GFR, is the gold standard. It shows how much blood the kidneys filter per minute. A normal GFR is around 90 to 120 milliliters per minute. Another common test is serum creatinine, a waste product in the blood. Higher levels can signal kidney issues. Then there's the blood urea nitrogen, or BUN, which measures urea levels, and a high BUN can point to kidney dysfunction too. Urinalysis also helps by checking for protein, blood, or other abnormalities in urine. These tests together give a solid picture of kidney health. Want me to break down any of these tests further?
This is
Or move to
great. I want to ask you about some general tests too. For instance, what can EPO production tell us, or vitamin D3, or excretion?
Okay, let's unpack those. EPO, or erythropoietin, is a hormone the kidneys produce to stimulate red blood cell production. Low EPO levels can signal kidney dysfunction, often leading to anemia, especially in chronic kidney disease. Testing EPO levels helps diagnose if kidney issues are behind low red blood cell counts. For vitamin D3, the kidneys convert inactive vitamin D into its active form, calcitriol. If kidney function is impaired, you might see low calcitriol levels, which can mess with calcium absorption and bone health. Excretion tests, like 24-hour urine collection, measure how well kidneys clear substances like creatinine, electrolytes, or protein. Excessive protein in urine, called proteinuria, often points to kidney damage. These markers give clues about specific kidney roles beyond just filtration. Want to
I
zoom in
see.
on
And can you talk to us a bit more about bedside clinical data and symptoms we might see and we might think, I wonder about the renal function of this patient?
Absolutely. Bedside clinical data and symptoms are critical for suspecting kidney issues. You might notice a patient with fatigue, swelling in the legs or ankles, edema, or puffiness around the eyes, often tied to fluid retention from poor kidney filtration. High blood pressure is another red flag, as kidneys regulate blood pressure, and dysfunction can spike it. Look for changes in urination, reduced output, foamy urine, hinting at proteinuria or blood in the urine, hematuria. Patients might complain of itchy skin or a metallic taste in the mouth, both linked to waste buildup. At the bedside, check for flank pain, which could suggest kidney inflammation or stones. A quick dipstick urinalysis can show protein, glucose, or blood in the urine, pointing to kidney trouble. If you see these, it's time to dig deeper with blood tests or imaging. Want me to
Question.
connect this?
What about modern imaging techniques? What do I use? Rhinography, gamma camera planar scintigraphy, positron emission tomography, single photon emission computerized tomography. Tell us about these, because I don't know what they mean. They're just fancy words to me at the moment.
No problem. Let's break down these imaging techniques for kidney assessment. They're not just fancy words, they're powerful tools. Rhinography, often done with a radioisotope, tracks how kidneys filter and excrete a tracer, showing blood flow and function. It's great for detecting blockages or reduced function. A gamma camera planer, used in scintigraphy, captures images of the kidneys after a radioactive tracer is injected, giving a 2D view of kidney activity. Think of it like a snapshot of how well each kidney is working. Scintigraphy itself is the broader term for these nuclear medicine scans, often used to assess kidney scarring, obstructions, or abnormal growths. Positron emission tomography, or PET, isn't routine for kidneys, but can be used to evaluate kidney tumors or metabolic activity by detecting positron emitting tracers. Single photon emission computerized tomography, or SPECT, is like scintigraphy, but creates 3D images, offering more detail on kidney structure and function, especially for complex cases like transplant evaluation. Each has its niche: renography and scintigraphy for function, PET for rare tumor cases, and SPECT for detailed 3D insights. Want me to explain how one of these is done in practice or tie it to clinical symptoms?
That's so good. Okay, and you mentioned blood urea nitrogen, creatinine. So, how would we measure creatinine? Does it have to do with and explain to us like it's a breakdown product of phosphate in the muscle basically, and tell us when it would increase and when it would decrease. For instance, how does muscle mass play a role into this, or pregnancy?
All right, let's dive into creatinine and how we measure it. Creatinine is a waste product from creatine phosphate, which muscles use for energy. It's produced at a fairly constant rate, filtered by the kidneys, and excreted in urine. To measure it, we typically use a blood test to check serum creatinine levels, reported in milligrams per deciliter. Normal ranges are roughly 0.6 to 1, 2 for men, and 0.5 to 1.0 for women, though this varies slightly by lab. You can also measure creatinine clearance with a 24-hour urine collection alongside a blood sample, which shows how efficiently kidneys clear creatinine. Normal is about 90 to 140 milliliters per minute. Now, when does creatinine increase? It goes up when kidney function drops, like an acute kidney injury or chronic kidney disease, because the kidneys aren't filtering it out effectively. Other causes include dehydration, which reduces blood flow to the kidneys, or conditions like rhabdomyolysis, where muscle breakdown floods the system with creatinine.
I see. I'm just gonna remind you, Grog, for the next 500 messages and in general in the podcast, let's try to keep it nice and back and forth. So try to be as efficient and as effective with your words, using the least amount of words while also putting your point across. Having said that, let's talk a bit about plasma urea now. So, what produces urea in the first place, and also what increases it and what decreases it? For instance, protein intake, hypercatabolic conditions, malnutrition, liver disease, how do these play a role?
Got it. I'll keep it tight and conversational. Urea is produced in the liver during protein metabolism, where ammonia from amino acid breakdown is converted into urea for kidney excretion. Plasma urea, measured as blood urea nitrogen, BON, normally ranges from 7 to 20 milligrams per deciliter. BON rises with high protein intake as more amino acids fuel urea production, or in hypercatabolic states like fever, trauma, or burns, where tissue breakdown ramps up. Dehydration also spikes BON by reducing kidney blood flow. Gastrointestinal bleeding can increase it too, as digested blood proteins get metabolized. BON drops in malnutrition, since low protein intake cuts urea production, or in liver disease, where impaired liver function limits urea synthesis. Pregnancy can lower BON due to increased kidney filtration. Want to dive deeper into any of these or shift to diuretics?
I would like to ask you about renal clearance. Explain us what clearance is, and also explain us when renal clearance we will have excreted equaling GFR, when it's going to be smaller and when it's going to be bigger.
All right. Renal clearance is how quickly kidneys remove a substance from the blood, measured in milliliters per minute. It's calculated by comparing the amount of a substance excreted in urine to its concentration in plasma. Glomerular filtration rate, or GFR, reflects the volume of blood filtered by the kidneys per minute, typically 90 to 120 milliliters per minute in healthy adults. Clearance equals GFR for substances like inulin, which are freely filtered and neither reabsorbed nor secreted by the kidneys. Clearance is less than GFR for substances reabsorbed by the kidneys, like glucose or sodium, where much of what's filtered gets taken back into the blood. Clearance exceeds GFR for substances actively secreted into the urine, like creatinine or certain drugs, as the kidneys add more to the urine beyond what's filtered. Want me to clarify any examples or
Well,
move
that
to another
makes a lot of sense. That makes a lot of sense. Why don't we talk a bit about this equation that the clearance equals the concentration of X substance in urine times the volume of urine formed in a given time over the concentration of X in blood.
You got it. The clearance equation is straightforward. Clearance of a substance X equals the concentration of X in urine multiplied by the urine flow rate, volume of urine per unit time, divided by the concentration of X in plasma. Mathematically, it's C equals U, X times V equals P, X, and par, where C is clearance, U, X is urine concentration of X, V is urine flow rate in milliliters per minute, and Px is plasma concentration of X. This gives you clearance in milliliters per minute, showing how much plasma is cleared of X per minute. It's key for assessing how kidneys handle substances, whether they're filtering, reabsorbing, or secreting them. For example, if X is creatinine, clearance approximates GFR, but is slightly higher due to secretion. Want me to walk through a sample calculation or connect this to specific substances?
Well, you already mentioned creatinine and inulin, which are good examples. I want to understand the drawbacks of using inulin to measure GFR.
Inulin's the gold standard for measuring GFR because it's freely filtered by the kidneys, not reabsorbed or secreted, so its clearance directly reflects filtration rate. But it has drawbacks. First, it's not naturally in the body, so you need to infuse it intravenously, which is invasive and time-consuming. The setup requires steady-state plasma levels, demanding precise timing and monitoring. Collecting urine accurately, often via a catheter, adds complexity and discomfort. Inulin assays are also specialized, not routine in most labs, making it expensive and less accessible. Plus, it's impractical for frequent testing or in outpatient settings. That's why creatinine clearance is often used instead, despite its minor secretion issue. Want me to compare these further or shift gears?
I want us to talk a bit about creatinine clearance more. Why does the colorimetry method used to measure creatinine, the Jaffe method, underestimates creatinine concentration? And why does using the equation U creatinine times volume over plasma creatinine will give us an overestimate? Is it because creatinine is filtered in the glomerulus, but also some of it is secreted? And if yes, then tell us more about it. And tell us how these two errors cancel out each other.
All right, let's unpack this. The Jaffe method, a colorimetric technique for measuring creatinine, can underestimate creatinine concentration because it's not entirely specific. Non-creatinine chromogens in plasma, like glucose or bilirubin, react with the reagent, artificially inflating the measured creatinine level, but in some cases, it underestimates due to interference from substances like ketones or drugs, which disrupt the reaction's accuracy. Now, the creatinine clearance equation, urine creatinine concentration times urine volume divided by plasma creatinine overestimates GFR. This happens because creatinine isn't just filtered at the glomerulus. The kidneys also secrete a small amount into the urine via the tubules, adding extra creatinine beyond what's filtered. This makes clearance, typically 100-140 milliliters per minute, higher than true GFR, 90-120 milliliters per minute. Interestingly, these errors can partially cancel out. The Jaffe method's tendency to overestimate plasma creatinine due to chromogens reduces the denominator in the clearance equation, which would increase clearance. Meanwhile, tubular secretion inflates the numerator, urine creatinine, also boosting clearance. In practice, these opposing effects balance out enough that creatinine clearance is a decent GFR estimate, though not perfect. Want me to dig into fixes for these errors or move on?
Let's talk about adjustments to creatinine clearance due to body surface area. So the corrected creatinine clearance. Few sentences only.
Creatinine clearance is adjusted for body surface area, BSA, to account for differences in body size, ensuring accurate GFR estimates. The corrected clearance is calculated by multiplying the raw clearance by 1.73, standard BSA in square meters, and dividing by the patient's BSA. This is crucial for kids, obese patients, or those with unusual body sizes, where unadjusted values can mislead. Most labs report corrected creatinine clearance for better comparison across individuals. Want to explore BSA formulas or shift topics?
I want to ask about kidney injury molecule 1, cystatin C. What are these biomarkers?
Kidney injury molecule 1, KIM1, and cystatin C are biomarkers for detecting kidney damage, especially acute kidney injury, AKI. KIM1 is a protein expressed on the surface of injured kidney tubule cells, detectable in urine when damage occurs, making it a sensitive marker for early AKI, like after surgery or toxin exposure. Cystatin C is a small protein produced by all nucleated cells, filtered by the kidneys and measured in blood. Unlike creatinine, it's less affected by muscle mass, age, or diet, so elevated serum levels signal reduced kidney filtration, often catching AKI or chronic kidney disease earlier. Both outperform creatinine for early detection, but can't distinguish AKI from chronic kidney disease alone. Want more on their clinical use or another topic?
So, okay, let's talk about the Cockcroft Gold formula then. Explain every component of it and also the modification of diet in renal disease formula and explain the components there too.
All right, let's break these down concisely. Cockcroft-Gault formula estimates creatinine clearance, CrCl, to approximate GFR. Formula: CrCl equals 140 times weight kilograms plus present dollar value, which is 0.85 if female, plus 72 times serum creatinine milligrams DL. Components: age, GFR declines with age, so older age lowers creatinine. Weight reflects muscle mass, as more muscle produces more creatinine. Sex, 0.85 for females, accounts for lower muscle mass in females. Serum creatinine, higher levels indicate worse kidney function, reducing creatinine. It's widely used for drug dosing, but less accurate in extremes of weight or age. Modification of diet and renal disease, MDRD, formula estimates GFR directly. Simplified version: eGFR plus 185 times serum creatinine milligrams DL minus 1.154 plus times age divided by 0.203 plus times 0.742 if female plus times American. Components: serum creatinine, inverse power reflects its impact on filtration. Age, Adjust for age-related GFR decline. Sex, 0.742 for females, adjust for lower muscle mass. Race, 1.212 for African American, accounts for higher muscle mass or creatinine production. MDRD is lab standardized, better for chronic kidney disease staging, but less reliable in healthy or obese patients. Want to compare their clinical uses or move to another topic?
I want to ask you about the clearance of para-aminohippuric acid. What's that?
Para-aminohippuric acid, PAH, clearance measures renal plasma flow, RPF, the volume of plasma delivered to the kidneys per minute, typically around 650 milligrams per minute. PAH is ideal because it's freely filtered by the glomerulus and actively secreted by the proximal tubules, clearing nearly all PAH from renal blood in one pass. Extraction ratio, minus 0.92. The clearance is calculated as urine PAH concentration times urine flow rate times plasma PAH concentration. Unlike GFR markers, like inulin, PAH clearance reflects total blood flow to the kidneys, not just filtration. It's used in research or specialized settings to assess kidney function, but requires IV infusion and precise urine collection, so it's not routine. Want more on its applications or another topic?
I would like to understand this a bit more. I didn't understand this PAH.
No worries. Let's simplify PAH clearance. Para-aminohippuric acid, PAH, is a substance injected into the blood to measure how much plasma flows through the kidneys per minute, called renal plasma flow, RPF. The kidneys filter PAH and actively pump it out through the tubules, removing almost all of it from the blood in one pass. You calculate clearance by dividing the amount of PAH in urine concentration times urine volume, by its concentration in plasma. This gives you RPF, roughly 650 milligrams per
I
minute
see.
in health.
Okay, now let's go to some general GI anatomy questions. These are going to be a bit all over the place, but I've gathered them and I kind of want to ask them. Can you tell me a bit about the common bile duct's function, which maybe it's not anatomy, guys, but this is my question. And also, I want to know a bit more about the falciform ligaments.
All right, let's tackle these GI topics. The common bile duct's job is to carry bile from the liver and gallbladder to the small intestine, specifically the duodenum, where bile helps digest fats by emulsifying them. It's formed by the union of the cystic duct from the gallbladder and the common hepatic duct from the liver, and it usually joins the pancreatic duct at the sphincter of Oddi, which controls bile release. Blockages, like gallstones, can cause jaundice or pain. The falciform ligament is a sickle-shaped fold of peritoneum that anchors the liver to the anterior abdominal wall and diaphragm. It separates the liver's left and right lobes and contains the ligamentum teres, a remnant of the fetal umbilical vein. It doesn't have a major functional role, but helps stabilize the liver's position. Want me to dive deeper into either or keep going with GI anatomy?
I want you to talk to me a bit about the hepatic portal vein and the common hepatic artery and similar arteries that I get confused. Maybe if we could start from the big ones and go to the smaller ones so I can understand a bit of the hierarchy of and the branching.
Let's clarify the hepatic vascular system, starting big and going smaller. The hepatic portal vein carries nutrient-rich, oxygen-poor blood from the digestive organs, stomach, intestines, spleen, to the liver for processing. It's formed by the union of the superior mesenteric vein and splenic vein, delivering about 75% of the liver's blood supply. The common hepatic artery, a branch of the celiac trunk, supplies oxygen-rich blood to the liver, contributing the remaining 25%. It arises from the aorta via the celiac trunk and feeds the liver, gallbladder, and parts of the stomach and pancreas. From here, the common hepatic artery branches into the proper hepatic artery, which enters the liver. The proper hepatic artery then splits into right and left hepatic arteries, supplying the liver's right and left lobes. Smaller branches, like the cystic artery to the gallbladder, also come off the hepatic arterial system. Within the liver, these arteries further divide into arterioles, feeding the liver's sinusoids alongside portal vein branches. This dual blood supply mixes in the liver to support its metabolic work. Want me to map out more branches or focus on a specific part?
This was great. I wanted to talk a bit about the layers of the abdominal wall from superficial to deep. So we've got the Camper's fascia, and then we've got Scarpa's fascia, and then we've got external and internal oblique, and we've also got a transversus abdominis. We've got transversalis fascia, extraperitoneal fat, and parietal peritoneum. And it's really hard for me to understand this kind of abstract order. Maybe if you could drop us some wisdom.
Tudo bem, vamos esclarecer isso de forma
And
simples.
remember, every time you hear me talk and you think I'm speaking another language, I want you to say, got me, because I don't want you to answer in another language. I want you to continue speaking in English. And this is true for the next 500 messages of our podcast.
Haha, got me. All right, let's stick to English and clear up the abdominal wall layers from superficial to deep, addressing your confusion about the abstract order and things like extraperitoneal or peritoneum. Starting at the surface, first, you've got the skin, then the subcutaneous tissue, which includes fat and superficial fascia, like Camper's fascia, fatty, and Scarpa's fascia, membranous, deeper. Next come the muscles, external oblique, internal oblique, and transversus abdominis, each with their fascia. Below the muscles is the transversalis fascia, a thin layer. Then you hit the extraperitoneal fat, a preperitoneal layer that cushions the peritoneum. Finally, the parietal peritoneum, the thin membrane lining the abdominal cavity. The confusion about extraperitoneal and peritoneum comes from their roles. Extraperitoneal tissue sits outside the peritoneal cavity, supporting organs, while the peritoneum wraps the cavity and organs like a sac. Think of it as layers of wrapping, from skin to a final cling film-like peritoneum. Want me to focus on a specific layer or move to another GI topic?
Let's talk about the rectus sheath now. And I want us to touch on the arcuate line and the anterior and posterior lamina.
The rectus sheath is a fibrous envelope around the rectus abdominis muscles, formed by the aponeuroses, flat tendons of the external oblique, internal oblique, and transversus abdominis. Above the arcuate line, roughly halfway between the umbilicus and pubis, the sheath has an anterior and posterior lamina. The anterior lamina is made of external oblique and part of internal oblique aponeuroses, while the posterior lamina includes the rest of the internal oblique and transversus abdominis aponeuroses, with transversalis fascia underneath. Below the arcuate line, all three aponeuroses pass anteriorly, forming only an anterior lamina, leaving just transversalis fascia and peritoneum behind the rectus abdominis. The arcuate line marks this shift, affecting surgical approaches and hernia risk due to weaker posterior support below it. Want more on its clinical relevance or another GI topic?
I want to ask you about inguinal hernias. Explain to me indirect and direct and indirect. So direct for some reason means acquired, so you'd have to explain that. And why indirect means congenital. And why is indirect medial to inferior epigastric artery and indirect is lateral?
Inguinal hernias occur when abdominal contents protrude through the inguinal canal. There are two types, direct and indirect. Indirect inguinal hernias are congenital, meaning they're due to a defect present at birth. They happen when the processus vaginalis, A peritoneal outpouching fails to close, allowing contents like bowel to slide through the deep inguinal ring, lateral to the inferior epigastric artery, into the canal. They're lateral because they originate outside the artery's path. Direct inguinal hernias are acquired, caused by weakness in the abdominal wall, often from aging, strain, or injury. They push directly through the inguinal canal's posterior wall, medial to the inferior epigastric artery and Hesselbach's triangle. They're medial because they bulge through the weakened floor, closer to the artery. The terms direct and indirect describe the path. Indirect follows the congenital route. Direct takes a straight, acquired path. Want me to cover diagnosis or treatment next?
I want you to talk to me about the anterior border and the superior border and the posterior and inferior border of the inguinal canal and the conjoint tendon.
The inguinal canal is a passage in the lower abdominal wall with distinct borders. The anterior border is primarily the aponeurosis of the external oblique muscle, reinforced laterally by internal oblique fibers. The superior border, or roof, is formed by the arched fibers of the internal oblique and transversus abdominis muscles. The posterior border, or floor, is made up of the transversalis fascia, strengthened medially by the conjoint tendon, a fusion of the internal oblique and transversus abdominis aponeuroses. The inferior border is the inguinal ligament, a folded edge of the external oblique aponeurosis running from the pubic tubercle to the anterior superior iliac spine. The conjoint tendon supports the posterior wall, resisting hernias, especially direct ones, by reinforcing the weaker medial floor. Want more on hernia implications or
That's
another
very
topic?
good. Okay. Now, I want to ask you about portal hypertension. I want to touch on caput medusae, esophageal varices, and anorectal varices. What are these?
Portal hypertension is high blood pressure in the portal vein system, often due to liver disease like cirrhosis, obstructing blood flow. Caput medusae refers to dilated veins around the umbilicus, visible as a snakehead pattern, caused by portal blood shunting through umbilical veins to systemic circulation. Esophageal varices are swollen veins in the lower esophagus, formed when portal blood backs up into systemic veins. They can rupture, causing severe bleeding. Anorectal varices are dilated veins in the rectum, distinct from hemorrhoids, resulting from portosystemic shunting in the lower GI tract. All three are signs of severe portal hypertension, reflecting the body's attempt to bypass liver obstruction. Want to dive into causes or treatments?
I want to ask you about portosystemic anastomosis. What's that?
Portosystemic anastomosis refers to natural connections between the portal vein system, which carries blood from the gut to the liver, and the systemic venous system, which returns blood to the heart. These connections act as bypass routes when portal hypertension, often from liver cirrhosis, blocks normal flow through the liver. Key sites include the esophagus, forming esophageal varices, the umbilicus, caput medusae, and the rectum, anorectal varices, where portal veins like the left gastric, umbilical, or superior rectal veins link with systemic veins like the azygos, superficial epigastric, or middle rectal veins. These shunts divert blood but can cause complications like variceal bleeding. Want more on specific shunts or their management?
I want to ask about referred abdominal pain and explain to us midline dermatomes and convergent spinal roots while you're at it.
Referred abdominal pain is when pain from an internal organ is felt in a different area, like shoulder pain from a gallbladder issue, due to shared nerve pathways. It happens because visceral nerves from organs and somatic nerves from skin or muscles converge at the same spinal cord segments, confusing the brain about the pain source. Midline dermatomes are skin areas innervated by specific spinal nerves along the body's midline, roughly T6 to T10 for the upper to lower abdomen. For example, T6 covers the epigastrium, T10 the umbilical area. Convergent spinal roots refer to the spinal cord levels, like T6 T9 for the stomach, or T10 L1 for the intestines, where visceral afferents from abdominal organs and somatic afferents from dermatomes meet, causing overlap. This is why appendicitis pain might start vaguely near the umbilicus, T10, before localizing. Want examples of specific organ pain referrals or another topic?
I want to also ask about the lesser sac. What's the lesser sac?
The lesser sac, or omental bursa, is a peritoneal cavity behind the stomach, separated from the greater sac, the main peritoneal cavity, by the stomach, lesser omentum, and gastrocolic ligament. It's bordered by the liver anteriorly, pancreas and spleen posteriorly, and communicates with the greater sac via the epiploic foramen. It acts as a potential space, usually collapsed, but can collect fluid in conditions like pancreatitis or internal bleeding. Its role is mainly anatomical, providing a cushion and allowing stomach movement. Want to explore its clinical significance or another GI topic?
I would like to ask about the portal triad now and Pringle's maneuver.
The portal triad, found in the liver's portal areas, consists of three structures: the portal vein, carrying nutrient-rich blood from the gut, the hepatic artery, supplying oxygenated blood, and the bile duct, draining bile to the gallbladder or intestine. These run together in the liver's functional units, supporting metabolism and detoxification. The psoas sign, not Pangol's maneuver, is a clinical test for appendicitis or psoas muscle irritation. It's elicited by flexing the right hip against resistance or extending the hip while lying on the left side. Pain suggests inflammation near the psoas, like from a retrocecal appendix. Want more on liver anatomy or other clinical signs?
Well, I didn't really understand these last things you said. So what's the portal triad and the Pringle's maneuver?
All right, let's clarify. The portal triad is a group of three structures in the liver. The portal vein brings nutrient-rich blood from the gut. The hepatic artery delivers oxygenated blood, and the bile duct carries bile out. They travel together in the liver's portal areas, supporting its functions like detox and bile production. Pringle's maneuver is a surgical technique, not a pain test, used to control liver bleeding during surgery. It involves clamping the hepatoduodenal ligament, which contains the portal triad, to temporarily stop blood flow to the liver. This reduces bleeding while working on liver injuries or resections. Want more details on either or a different topic?
I want to ask you now, let's go to diuretic agents, our last topic of the day. So we have two modes of action of diuretics: direct action on the cells of the nephron and modification of content of the tubular fluid. Could you explain this a bit more?
Diuretics increase urine output by targeting the nephron, the kidney's filtration unit, and work via two main mechanisms. Direct action on nephron cells involves diuretics binding to specific transporters or channels in the nephron's tubular cells. For example, loop diuretics like furosemide block the sodium-potassium chloride cotransporter in the loop of Henle, preventing sodium reabsorption, so more sodium and water stay in the urine, increasing output. Thiazines, on the other hand, inhibit sodium chloride reabsorption in the distal tubule. Modification of tubular fluid content affects what's in the urine to drive diuresis. Osmotic diuretics, like mannitol, stay in the tubular fluid, raising its osmolarity, which pulls water into the urine by osmosis, reducing reabsorption. Both mechanisms ultimately boost urine volume, but diuretics tweak cellular transport, while fluid modification changes urine composition. Want to dive into specific diuretics or their clinical uses?
I want to ask how they help with glaucoma and epilepsy.
Diuretics help with glaucoma and epilepsy through distinct mechanisms. In glaucoma, carbonic anhydrase inhibitors like acetazolamide reduce aqueous humor production in the eye by inhibiting bicarbonate formation in the ciliary body, lowering intraocular pressure. Osmotic diuretics, like mannitol, also draw fluid out of the eye, further reducing pressure in acute cases. For epilepsy, acetazolamide is used off-label. It mildly acidifies the brain's extracellular fluid by reducing bicarbonate, which can stabilize neuronal activity and reduce seizure frequency. especially in certain pediatric or refractory cases. These effects aren't directly tied to their diuretic action, but leverage their impact on fluid or acid-base balance. Want more on specific diuretic types or side effects?
Um, well, I want to get into the different types of diuretics and where they act in the nephron.
All right, let's break down the main types of diuretics and where they act in the nephron. 1. Loop diuretics, e.g., furosemide, act on the thick ascending limb of the loop of Henle, blocking the sodium-potassium chloride cotransporter, preventing sodium reabsorption, leading to significant water loss. Thiazide diuretics, e.g., hydrochlorothiazide, target the distal convoluted tubule, inhibiting the sodium chloride cotransporter, reducing sodium and water reabsorption, but less potent than loop diuretics. Potassium-sparing diuretics, e.g., spironolactone, amuloride, work in the collecting duct. Spironolactone blocks aldosterone receptors, while amuloride inhibits sodium channels, both reducing sodium reabsorption while sparing potassium. Carbonic anhydrase inhibitors, e.g., acetazolamide, act in the proximal tubule, blocking bicarbonate reabsorption, which increases sodium and water excretion but is weak for diuresis. Osmotic diuretics, e.g., mannitol, affect the proximal tubule and loop of Henle by staying in the tubular fluid, pulling water into the urine via osmosis. Each targets a specific nephron segment to boost urine output.
Okay, so let's talk a bit about loop diuretics like furosemide. So, why are they called high ceiling diuretics, and how exactly do they inhibit the sodium potassium chloride transporters NKCC2? Please say the full name, sodium potassium, don't say the elements because you fuck it up. Why specifically in the thick ascending limb? And yeah.
Loop diuretics, like furosemide, are called high-ceiling diuretics because they produce a massive diuretic effect, excreting up to 20-30% of filtered sodium, far more than other diuretics, with a steep dose-response curve. They act in the thick ascending limb of the loop of Henle, where they inhibit the sodium-potassium chloride cotransporter, NKCC2, not KCC2, which is in neurons. NKCC2 normally reabsorbs sodium, potassium, and chloride from the tubular fluid back into the blood. Furosemide binds this transporter, blocking reabsorption, so sodium, chloride, and water stay in the urine, driving significant diuresis. The thick ascending limb is targeted because it handles a large portion of sodium reabsorption and sets up the kidney's concentration gradient, making it a high-impact site. Want more on their effects or side effects?
Okay, let's talk a bit about the loop diuretics uses and the unwanted effects like dehydration and hypokalemia, but also the uses in pulmonary edema, heart failure, cirrhosis of the liver.
Loop diuretics, like furosemide, are powerhouses for increasing urine output and are used in conditions with fluid overload. In edema, they reduce swelling from conditions like heart failure or kidney disease by flushing out excess sodium and water. In heart failure, they ease pulmonary congestion and reduce cardiac workload. In liver cirrhosis, they manage ascites, abdominal fluid buildup, by promoting fluid excretion. But they come with unwanted effects. Dehydration is a risk from excessive fluid loss, causing dizziness or low blood pressure. Hypokalemia, low potassium, happens because they increase potassium excretion, potentially leading to arrhythmias or muscle weakness. Other issues include low magnesium, low sodium, and ototoxicity, hearing damage with high doses. Careful monitoring is key to balance benefits and risks. Want more on dosing or monitoring strategies?
I want to ask you a bit about thiazide diuretics and the sodium chloride co-transporter.
Thiazide diuretics, like hydrochlorothiazide, act in the distal convoluted tubule of the nephron, targeting the sodium chloride cotransporter, NCC. This cotransporter normally reabsorbs sodium and chloride from the tubular fluid back into the blood. Thiazides inhibit it, preventing sodium and chloride reabsorption, so more stays in the urine, pulling water along and increasing urine output. They're less potent than loop diuretics, excreting about 5–10% of filtered sodium. They're commonly used for hypertension and mild edema because they reduce blood volume and relax blood vessels. A key side effect is hypokalemia, as increased sodium delivery to the collecting duct boosts potassium excretion. Want more on their clinical uses or side
I
effects?
want you to tell me about indapamide and how the name relates to the structure and function. But also, since you mentioned hypokalemia, explain why exactly it happens. So we have increased loss of potassium in the urines. So why do we have that?
Indapamide is a thiazide-like diuretic, structurally related to thiazides, but with an indole-derived ring, which inspired its name, indole plus amide. It acts on the sodium chloride cotransporter in the distal convoluted tubule, blocking sodium and chloride reabsorption, increasing urine output. Its vasodilatory properties, unique among thiazides, enhance its use in hypertension. Hypokalemia occurs because thiazides, including indapamide, increase sodium delivery to the collecting duct. There, sodium is reabsorbed via epithelial sodium channels, which triggers potassium excretion into the urine to maintain electrical balance, driven by aldosterone. This potassium loss lowers blood potassium, risking hypokalemia. Want more on indapamide's benefits or managing
Well,
hypokalemia?
let's speak about potassium-sparing diuretics like spironolactone and eplerenone, and explain to me how these will spare potassium. But in the first place, I don't really understand why we would lose. Well, I understand why we would lose potassium, but I don't understand why we would reabsorb sodium, since sodium's supposed to be peed, right? Since we want more urine output.
All right, let's clear this up. Potassium-sparing diuretics like spironolactone and eplerenone work in the collecting duct to reduce potassium loss. Normally, sodium is reabsorbed in the collecting duct via epithelial sodium channels, ENaC, which creates an electrical gradient that drives potassium excretion into the urine. Spironolactone and eplerenone block aldosterone receptors, which normally upregulate ENaC and sodium reabsorption. By inhibiting aldosterone, they reduce sodium reabsorption, so less potassium is excreted, sparing it and preventing hypokalemia. Now, why reabsorb sodium at all if we want to pee it out with diuretics? In healthy kidneys, sodium reabsorption is tightly regulated to maintain blood volume and blood pressure. Diuretics like thiazides, or loops, block sodium reabsorption upstream, increasing sodium delivery to the collecting duct. There, aldosterone-driven sodium reabsorption kicks in to conserve some sodium, which unfortunately promotes potassium loss. Potassium-sparing diuretics counter this by limiting sodium reabsorption at that final step, balancing sodium output while protecting potassium. Want more on their uses or side effects?
I want to ask you about spironolactone, how it can cause metabolic acidosis. Just tell me in a sentence or so.
Spironolactone can cause metabolic acidosis by inhibiting aldosterone, which reduces hydrogen ion excretion in the collecting duct, leading to acid accumulation in the blood. Want more details or a different topic?
What about non-aldosterone antagonists like amiloride or triamterene? So these act on the distal tubule to inhibit sodium reabsorption. They block the sodium channels. What can you say about this in comparison to the rest of them?
Non-aldosterone antagonist potassium-sparing diuretics, like amiloride and triamterene, act in the late distal tubule and collecting duct, directly blocking epithelial sodium channels, ENaC. Unlike spironolactone, which inhibits aldosterone signaling, These drugs physically stop sodium reabsorption through ENAC, reducing the electrical gradient that drives potassium excretion, thus sparing potassium. Compared to loop or thiazide diuretics, they're weaker, excreting only 1-2% of filtered sodium, so they're often combined with thiazides to counter hypokalemia. Amiloride is also used in rare conditions like Liddle's syndrome, while triamterene can cause urinary crystal formation. Both have a lower risk of hormonal side effects like gynecomastia than spironolactone. Want more on their specific uses or side effects?
I want to ask you about using diuretics in combination and why this might increase diuretic effects and it helps us avoid hypokalemia.
Combining diuretics, like a loop diuretic, e.g., furosemide, with a thiazide, e.g., hydrochlorothiazide, boosts diuretic effects because they target different nephron segments, loop of Henle and distal tubule, blocking sodium reabsorption at multiple sites. This synergistic action increases sodium and water excretion more than either alone, often used in severe edema or resistant hypertension. Adding a potassium-sparing diuretic, e.g., spironolactone or amiloride, helps avoid hypokalemia. Loop and thiazide diuretics increase sodium delivery to the collecting duct, promoting potassium loss. Potassium-sparing diuretics block sodium reabsorption there, reducing potassium excretion, balancing levels. Want specifics on combo dosing or
Yeah,
risks?
tell me about, let's say, spironolactone with loop diuretics or furosemide with amiloride or hydroflumethiazide with spironolactone. Tell me some combos.
Combining diuretics enhances efficacy and manages side effects. Spironolactone with loop diuretics, e.g., furosemide, is common in heart failure or cirrhosis with ascites. Furosemide drives sodium and water loss in the loop of Henle, while spironolactone blocks aldosterone in the collecting duct, sparing potassium to counter furosemide's hypokalemia risk. Furosemide with amiloride is used in edema or hypertension. Amiloride directly blocks sodium channels in the collecting duct, reducing potassium loss, and is less likely to cause hormonal issues like spironolactone. Hydroflumethiazide, a thiazide, with spironolactone treats hypertension or mild edema. Hydroflumethiazide inhibits sodium reabsorption in the distal tubule, and spironolactone prevents potassium depletion from thiazide-induced.
Okay, okay, we're nearly done. Let me ask about carbonic anhydrase inhibitors like acetazolamide and explain these to me too.
Carbonic anhydrase inhibitors, like acetazolamide, work in the proximus tubule of the nephron, where they block the enzyme carbonic anhydrase. This enzyme normally helps reabsorb bicarbonate, which pulls sodium and water back into the blood. By inhibiting it, acetazolamide reduces bicarbonate reabsorption, increasing sodium, bicarbonate, and water excretion in the urine, producing a mild diuretic effect, about 1-3% of filtered sodium. They're not used much for diuresis due to their weak effect, but are key for glaucoma, reducing eye fluid, altitude sickness, adjusting blood pH, or epilepsy, stabilizing neurons. Side effects include metabolic acidosis from bicarbonate loss and hypokalemia. Want more on their off-label uses or comparisons?
I want to ask about osmotic diuretics like mannitol now.
Osmotic diuretics, like mannitol, work in the proximus tubule and loop of Henle. They're large molecules that, when given intravenously, are filtered by the glomerulus but not reabsorbed. This increases the osmolarity of the tubular fluid, pulling water into the urine by osmosis, preventing water reabsorption and boosting urine output. Mannitol is used in acute settings, like reducing intracranial pressure in brain edema, lowering intraocular pressure in glaucoma, or preventing kidney damage in rhabdomyolysis. Side effects include dehydration, electrolyte imbalances, or fluid overload if not monitored. Want more on clinical scenarios or comparisons with other diuretics?
Can you tell me about water as an aquaretic agent? And yeah, explain it in regards to aquaporin channels and yes.
Aquaretics, like talvaptan or conivaptan, target aquaporin channels, specifically aquaporin 2 water channels in the collecting duct of the nephron. Unlike traditional diuretics that increase sodium and water excretion, aquaretics block vasopressin antidiuretic hormone receptors, particularly V2 receptors, which normally stimulate aquaporin 2 insertion into cell membranes to reabsorb water. By inhibiting this, aquaretics reduce water reabsorption, increasing urine output of mostly water, not electrolytes, which is why they're called aquaretics. They're used in conditions like hyponatremia or heart failure with fluid overload, where you want to correct low sodium or reduce water retention. Side effects include hypernatremia or thirst. Want more on their uses or how they differ from other diuretics?
I want to ask you about ADH antagonists. Talk to me about lithium and demeclocycline and tolvaptan.
ADH, antidiuretic hormone antagonists, also called vasopressin receptor antagonists, block vasopressin's action to reduce water reabsorption in the kidney. Telvaptan, a V2 receptor antagonist, acts in the collecting duct, preventing aquaporin 2 channel insertion, leading to increased water excretion without major electrolyte loss. It's used for hyponatremia in heart failure or SIADH, syndrome of inappropriate ADH secretion. Lithium, primarily a mood stabilizer, can act as an unintended ADH antagonist by desensitizing the kidney to vasopressin, causing nephrogenic diabetes insipidus, where patients excrete large amounts of dilute urine. It doesn't target vasopressin receptors directly, but disrupts signaling pathways. I think you meant demeclocycline, not maclorocycline. Demeclocycline, another ADH antagonist, also induces nephrogenic diabetes insipidus by reducing vasopressin sensitivity, used off-label for SIADH to increase water excretion. Telvaptan is more targeted and potent than demeclocycline or lithium, with fewer side effects like photosensitivity, demeclocycline or systemic toxicity, lithium. Want more on clinical applications or side
That's
effects?
all. Thank you so much for watching, guys. Peace.